Implant overdentures, that's what I'm going to be talking about now. And let's have a look. This is Kathleen here. So Kathleen's mouth, she's got these two studs at the bottom, and she's had an overdenture on that for not very long, about maybe 4 to 5 years, and she's really worn the balls off on the top of those studs there. So she came in with this problem because it wasn't fitting. It just was no retention whatsoever. So her options are, I gave her the options in terms of take off those attachments, put locator attachments in, because I use locators for implants and have done for years and years. Put locators in, change the insert in the denture, and then just make literally do that and keep the same denture. Or we actually make a new lower denture, and I much prefer to make a new lower denture so it is properly extended and beautifully supported by the saddles. And keeping this, Rowan's got a particular term for it. It's a Northern English term. It's called shit shining. So if we're going to keep it, or turd polishing, it's like an impossible mission to try and shine something like that. Anyway, now I gave Kathleen the options, and she decided just to go ahead and have the studs taken out and the locators put in. And I'll just show you exactly how I did that, because it's all really technique sensitive, just getting it to fit really well. So I take off the studs, take them out, and then put 2 locators in and fit them down, tighten them up, torque them in, and then take the denture through to the lab, and Rowan cuts out, whilst I'm putting my abutments in, Rowan's cutting out the attachments in the denture and just making sure he puts a really good undercut in the acrylic so that when I come to put my housing in there, it's going to grip properly. So it's just like a filling, so we've got a nice undercut on that. So I then take the denture straight back to the mouth and spray occlude onto it there, because I want to ensure that the denture fits passively in the mouth, because I've got my housings, so I've got on top of those locators, I've got the housings. Those housings are going to embed in the denture itself, and I've also got those little washers. They're PTFE washers that just go around the implant and actually stop the acrylic, which I'm going to use to actually put the housing in. It stops that acrylic from gluing to the abutment and preventing me from actually taking the denture out. So they're really important. But anyway, I've got my occlude on here like this. I then take that denture to the mouth. This is those here, and I push it over and then take it out. And if it's scratched off on the surface of those housings, then I just use a drill and just grind that away. Just get it off, because I want it to sit beautifully passively back down onto the soft tissues and not be slightly off on the implant, because if I set it at that slightly off position, when the patient bites together, they're going to have an occlusal issue, and it's also not going to actually touch the soft tissues properly. It's not going to be supported by the soft tissues. So that's what I do. And it's always when I come to actually cold cure the attachment in, it's squeaky bum time for me. That's like slightly worrying, because I'm always a little bit worried that I'm going to get the denture stuck onto the implants, and B, that it's also going to totally mess up the way it fits the denture as well. So, and I just want to put in just enough of this Oofy gel hard into that area as I need. I don't want to put too much in so it goes everywhere over the fitting surface. And Rowan's much more used to doing stuff like this in the lab, so I often get him to come through and stand next to me whilst I'm squirting that in there, and you can hear Rowan just in a minute go, okay. That's enough.
Okay.
I don't think we heard him, did we? I didn't hear him.
Okay.
He actually says, okay. Right, stop, that's enough. So it goes into the mouth like this. So I put that. So Claire, first of all, have you noticed, they're sandblasted, those housings. So we sandblast them first, so it makes the acrylic stick better. And make sure they're properly down before I actually pick up them in the mouth. So I make sure they're properly pushed down. I've got my neoprene on, put the denture over the top, and then push that in, and then make sure I wait for it to fully set. And whilst I'm doing this, so if you imagine I've got the denture over the top of those, that acrylic, we're waiting for it to set. We make sure we give it a good 5 minutes before I take it out, because I want it fully set, so I've got my timer there. And then wait for it, and this is really important. This is a really, really important point. I don't get the patient to bite together on their upper denture. I just hold it down with my hands on there and just make sure it's down onto the soft tissues myself, because as soon as I get the patient to bite together, they can go into like some weird excursive position and completely make it cockeyed. So I just hold it down whilst it's setting, that full 5 minutes. And then take it out, and hopefully I can get it out, because it's always a little bit nerve-wracking doing it. It's just like, you've got to grip it, because it can lock onto those abutments, and it's horrible having to grind the flipping thing out. So we've got our attachments nicely bonded in, and then I just tidy that up, and then I just use the weakest locator abutment I can, the least retentive, and then we can always ramp it up later, further on through the years of wearing this. So, and then we've got all different grips, but essentially we've got, these are the weakest ones, these two here. So we've got one with a male insert in the middle that fits into the locator, and then one without. And then these go up in terms of grip. I think it's 500 grams for these. It's 1,000, so 1K grip, and 1.5 with those. And they also supply this, which is completely non-retentive, that one, the grey one. And it's quite useful if you've got lots of implants and you just want it supported on one of them but not gripping, particularly if it's a weird angle, the implant. So I use the grey quite regularly too. And this tool here just helps me to get the locators out of the denture and actually fit these new attachments in. It's quite a neat little tool that comes with that system. So now I know locators aren't perfect at all. And quite often, particularly if the patient's not got great oral hygiene, food just gets shoved in to the top of the locators. And then when this is worn here, the dentures, it actually prevents the denture from seating. And quite often this centre male section there, particularly if the patient's not brushing very well, it'll get absolutely squidged up. And it won't seat, the denture will just not seat. So in these circumstances, what I do is I put a temporary filling Voco clip just into the top of the abutments, and then just instead of using a blue attachment, I'll use one with a open section in the middle, and it'll just go around the outside. So, and it's particularly good for patients that are not great with cleaning, like Alzheimer's patients. It's lovely, it's much better. So, and that just gets round that fitting problem. So, next patient I want to show, here's Ellen. So, Ellen has these full dentures in place. Let's have a look in the mouth. So in the lower, she's got this bar retained lower denture, but there's an issue with one of the implants that's completely failed. This IMZ implant just here has totally failed, and it's just sitting in granulation tissue. She did have another IMZ just here that was replaced with an Astra implant further on down the line before I actually saw her. So, and then she'd had a new bar made and a denture fitted, but the IMZ had failed. These are really old implant system we used to use a lot at Manchester Dental School. So in her circumstances, like Ellen is in her late 90s, she's quite a youthful late 90s lady, but there's really good evidence to show that if we take it out and then just put a locator attachment on, there's really good literature, particularly from Germany, about just a single implant in the lower jaw is really quite useful for holding the denture, and it really improves the patient's quality of life. They've actually done a lot of studies where they just stuck one in virtually around the midline and then made a lower denture, and it really helps. So it's just the same concept. I've just put that on there and then make her a really beautifully extended lower denture. And if you're looking at the impression, this is my definitive impression with the analog in. This is using silicones, but this is just after I've been to Japan and done Dr. Arbe's course, so I was experimenting with silicones, but I would normally use Impri gum for this impression now. So, but it worked beautifully, and we made this full lower to fit over that implant. Now, a technique that I really think is a really interesting approach to this is, I always think that if we process it in the lab and have the housing fitted here, that the denture doesn't quite fit onto the soft tissues properly, fully. So what I like to do is I actually fit it like this there, and actually get the patient to wear that until it's comfortable and do my adjustments. So it may be like 2 weeks, 3 weeks, do my adjustments, and I know that by that stage the denture has just sunk into the soft tissues and it's really well supported by the soft tissues, and then I attach the housing in. So that could be maybe like a month later, and attach it on here, and then fit the locator attachment on here. And I treated this lady years ago, and it's just been great. You know, she's really just got on beautifully with it. And the reason I put this picture up, this is a really important picture because it just reminds me to mention that when I'm doing implant work with overdentures, I don't throw away all of my prosthodontic principles. Basically, the denture looks just the same. It's the same extension, but with my attachments in, essentially. So it's fully up the retromolar pad covering, just like that Dr. Arbe design that I talked about yesterday. So, and here is Ellen. This is during the war. And this is a photograph of her, and she, understandably, it's with her mum. She didn't want to have her teeth looking like that, you know, her denture. So and she actually liked her daughter's teeth, and this is her daughter's teeth. She got upper crowns and slightly wonky lower teeth, and we just mimic that for her in the actual final denture. Now it's a little bit white. It isn't a 95-year-old patient. It's more of a sort of 30-year-old patient, but that's what she wanted. But it's just a little bit different, but looks miles better than what she came in with, and it's really improved her quality of life. You know, she can eat and chew and function perfectly well, and that implant is staying absolutely fine. So that's number one. This lady here, Anne, she was a great patient, an artist, and we made her an upper full denture. She's got lower 2 to 2, and the reason I'm putting her picture up is that the denture itself is carved, or the rim we carved according to all of those steps that I showed with carving the upper rim, which is like lip support, incisal plane, occlusal plane parallel to the ala tragus, And this making the occlusal plane parallel to the alar tragus is, I think, it's the key to getting great aesthetics. It really is. But what happens is, when we actually look at it on the model here, so this is Anne's mouth, just look at, she's combination syndrome, so she's lost that anterior ridge. If we go further back here, and I superimpose the denture, which looks really fantastic in a mouth here, if I superimpose the denture, there's no, if we were going to theoretically put implants in that area at the back, we'd have no space for them, because one of the main things that Rowan says to me is, I need more space for everything that he's doing. If there's an implant component underneath, whatever it is, be it a fixed bridge or a denture, there is often not enough space, or the implant is in the wrong place. And it just means that we can't actually put the teeth back where they were naturally. This is a massive deal. So if this lady was going to have a fixed restoration in the maxilla, it'd be as thin as anything here, wouldn't it? So there'd be virtually no room. And also for a locator attachment underneath it. So this is something I think we need to be mindful of, and often if we look at cases, fixed upper cases on implants, they look like they've got a dipping posterior occlusal plane. They are all teeth, and I just don't like the look of them. And this is why dentures just look better. And the reason is that once someone's been rendered edentulous, often the tuberosity grows. It actually grows down, and quite often the tuberosity is at a lower level than the occlusal plane of where the natural teeth used to be. It's quite a big deal, actually. So, need more space is Rowan's common complaint. So, anyway, this is Lynn here. So, Lynn was just totally embarrassed about her smile. Really was proper, hated it, reclusive, you know, at work, shied away from her colleagues, was just uncool about her teeth. And this is her mouth here, periodontally involved, also carious, not great. And we went through all the options in terms of, you know, partial dentures. Do we do partials? Do we do fulls? Do we do implants? And so once she considered all of those things, she had her heart set on dental implants, over-denture dental implants. So this is her mouth here. You know how she presented with these horrible partials with loads of glue underneath, and you know, functionally horrid. So this is what we decided to do. So just a normal approach, which is if I'm doing a full upper over-denture, 4 implants in the maxilla, and in the lower 2 implants. It's just very much according to the sort of standard guidelines, like ITI guidelines. So that was the approach that we took. So, this is like the standard approach, which is immediate upper and lower dentures and implant placement. So that would be phase 1. We do that. And then we connect the implants to the immediate dentures 3 months after the implants have been put in. And then wait, really be patient. I think we have to be, I want to be really patient. I want resorption. So wait for at least 9 months before we go ahead with the definitive dentures, and hopefully 12 months to really get some resorption. So that's the step approaches that I like to do. And so if we fast forward time, I have a surgeon that does the implants for me, but when the implants are going in, I and Rowan watch him, and we're making sure that he's using that guide here, because this guide is exactly where we want the teeth to be. So the surgical guide is just a copy of the lovely immediate denture that look great, and we want those implants, the locators, to be lingual. So we've got plenty of, Rowan has space to restore. He can actually position the teeth exactly where we want it aesthetically, and get the housing over the top of that. And also, because we like to metal reinforce the final denture, it's going to have chrome over it. It's going to have acrylic teeth over the top. We've also got the housing that fits over the implant. It's all quite a bit of space, even with that. So I just want it lingual, so it's not going to mess up that lovely aesthetic. It's exactly the same with the lowers as well. So if at all possible, I want, you know, Paul, who puts the implants in, Paul, move him in, please. And so he does his pilot holes, and we, you know, and then he's got his guide in there, so, you know, we just tip it in, you know, really, really anal about it, because if they're in the wrong place, it really does mess up the restoration at the end of the day. So here we are. So if we fast forward now 12 months, and we're now going to make the definitive dentures for her. So we've got the locator attachments on. So we've got 2 locators in the mandible. We've got 4 at the top, 4 implants. And also the other thing, whilst Paul is putting the implants in, this is dead important, I want them as parallel to each other as possible. And I know that the locator system, it says in their literature, it can cater up for like 40 degree differences in angles. That is not the case. It can't. If the implants are not parallel to each other, it really means that the attachments in the denture wear out much quicker. It's a much bigger problem. So again, when Paul's doing this, I just want them parallel too. It's really, really important. So I'm going to do my definitive impression on that. And for the upper impression and the lower, it's exactly the same principles as a complete denture. But my green stick stop, I can't put it on the top of those mushrooms. So I put my green stick stop in the palate here. So that just creates that space. And then I use Impregum over the top of that. And plenty of adhesive on the tray. Plenty of adhesive. It goes into the mouth. And I do all of the movements. And because Impregum is a slightly bit thicker than alginate, I really go for it with the border moulding. It's just the same, you know, so it goes in, cheek, and then waggle your jaw, coronoid process, and then make sure they just do that. I'll push that and then suck my finger. You know, all those set routines, it's just the same as if I was doing a complete denture. And same for the lower. So these are the impressions that I've taken here. Same for the lower, but in Impregum rather than alginate. So the impression process is just the same as for a complete denture. Rotate it in, push it down on there, and then hold it in place, and then get the patient to really go for it, going ee, woo, lick the lip. Push the tongue against the lower front teeth or the strut at the front there, and have a really good powerful swallow. And Impregum doesn't taste very nice when they're doing this, so I've just got to really encourage them whilst they're doing it. And I have the timer set, and it's particularly important. I've got my little stopwatch going because I don't want to take it out before it's set and I leave those mushrooms on top of the teeth. So make sure it's fully set. So, and then it's the usual process of looking at the photo, sending that through, and carving the rim appropriately, lip support, incisal plane, occlusal plane, buccal corridor, centre line, OVD, photo to Rowan, and then he sets the teeth up for her. Do a try-in video, make sure she's totally happy with the aesthetics. And this is really important. I don't do horseshoe dentures on top of locators. I just do a full palate. And I know patients, you think, we're going to put implants in, so you don't need a palate. But locators just don't work very well. I've had my fingers burnt with this, you know, so where I've done horseshoes in the past for patients, you know, we've got the implants in where we can get them, and then, you know, Paul rings me up, you know, I'm on holiday, rings the emergency phone, my implant's come out in my denture, pulled out. And it stresses me, but a horseshoe-shaped denture, I think, stresses the implants too much and is not supported by the posterior. The palate and vault of the palate offers great support and stability for the implants. So I don't do a horseshoe in the upper if the implants are not splintered. You know, if they're splintered, it's okay. So here we've got her dentures just at the beginning, just ready to fit now. So we've got a chrome incorporated into both the upper and lower, which I like to do, and I'll show you how we design that chrome specifically just in a minute. But we've got no attachments in, and then I fit the dentures, and then she wears them until they are comfortable, both upper and lower, without it attaching to the implants. So make them fully comfortable so they're just sitting and sunk into the soft tissues and beautifully supported. This is denture. She's got a big overjet. You can't tell when it's fitted. It looks great, but this is the arrangement. So putting the teeth back where they were naturally. And this is the lower here without it attached to the implants. I hope the sound's up, Daniel, please. Had nice suction on it. So, and that's without it actually attaching to the implants. So it's great. I promise it wasn't attached to the implants there. But anyway, we just left that until it's nice and comfortable, and then attached the attachments into the denture. So it's really nicely retentive on the implants, but it's also beautifully supported by all of the saddle area. So we're taking her from this to that, and she's really, you know, delighted with it, and she loves it. It totally changed her life. It's fantastic. And what we do is we've got the immediates here on the right hand side, just there, and we've got the final ones here. So she's got those immediates as a spare. So I do a reline. Once we've fitted the definitives, then we do a reline in the spare, so she's got that to take with her on holiday, just in case there's a problem or breakage. And also, she can have one. It doesn't mean that Rowan is stressed having to repair it really quickly. She can use her spares, and Rowan's got the luxury of just a couple of days to get it sorted better. It's nice. So, right. If I'm going to do a lower implant overdenture though, I show the patient this video here, because although they are really beautifully retentive and stable, they still pivot. So look at that. It's attached to the locators and it's really retentive, but there's still a rock on it. You know, it's still going to pivot. And I like to let the patients know that before we actually start, so that they know that it'll have a little bit of rock in it. It's not going to be totally solid. And just let them know. So, if we look at the chrome inside, the shape of it is a T shape, and the red line here is like the cross section here. And that is the shape of the chrome framework, and it's just an engineering thing. You know, you see it in those steel girders, the RSJs in construction. So it's really, really strong and rigid, T-shaped all the way back on the saddles, and so it's completely solid and it doesn't bend. It's a proper reinforcement that fits inside the denture. It's nice. And we do that upper and lower mainly. That's our sort of stock one. But if we've got a bruxist, someone that is really heavy on the teeth, then particularly if they've got lower anterior natural teeth and they're occluding on they brux, we put metal backings on the upper, and it really helps to strengthen the whole thing. You know, so it's, and we've got a lovely cage just underneath. These are really robust and strong, because I really don't like things breaking. You know, patients don't like it either. You know, it really knocks their confidence. And I've learnt the hard way with this. So in general, I reinforce all my over-denture locator dentures. So, and I just want to show you a bar case now, a bar sleeve one. It's more complex, but and take you right through the sequence. So here's Emmy, and she came in like this here, and let's have a look in the mouth. The dentist that was treating her was not able to finish the treatment. That's an immediate placement bridge with implants underneath. And so she came to me like this. If you look at the x-ray, these are really challenging, and this is a really common thing that I see is, you know, having to pick up the pieces. With having a referral practice is, look, we've got two Noble Biocare Replace Select implants up here, and we've got two Ankylos Dentsply implants here. We've got 3 TBR implants which are made in France here, and then we've got an Ankylos implant down here, and then a massive lower bridge that's okay-ish. But if we look at the top there, that implant has completely failed, the distal one, and this is just held in by a little bit of bone. But the others are not too bad actually. But what I do in these circumstances, Rowan and I want to know exactly where the screw access is going to come out and what's going on with those implants and where are they. So we've got to find out what makes they are, what screws go in, etc. And then I'll do a pick-up impression of the fixture head, the actual implants themselves. And you can see the screws are just like way out here. It's going to be really difficult. So the options for her, for Emmy, is to do, I feel, just to do a full denture. We can't, if I put locators on those, they're all going to be like that. And the locators just wear out really fast, and I'm not going to get it to sit properly. So in these circumstances, a full denture, what I would have done is I take off all the stuff on the top, put cover screws on, basically just put it to sleep, and just make a full upper denture with great suction. And that, I think, is the best option for these patients, really. However, she wanted a horseshoe-shaped restoration. And I didn't offer a fixed solution on that because it would be totally impossible to clean it if she just wouldn't get under it. So that's why a bar and a sleeve over the top, she can still clean under the bar. But after, you know, close consideration, this is what she wanted. She wanted the horseshoe-shaped denture. She really thought about it. She knew all the pros and cons. That's what she went for. So this was the approach to treatment for her, was to take a definitive impression. So I've got all my impression posts in, and I put floss around the nearest abutments, and then link that together with Luxabite. It's a bite registration material, it's a composite, Luxabite, and bead it on, let it set like that so it's not joined up, let it all shrink and set, and then add some more on so it's like a little mini bridge. And then I've got the special tray that Rowan's made with like a hole right in the top of it there. So these all stick through, and it enables me to actually take the impression and then undo the impression post and take the whole thing out. So I make sure that my tray is totally clear of those, and it's not going to scrape on that special tray. It's really important. So I'll trim away the tray. I want it back down onto the soft tissues. And think about, because I'm going to be making a sleeve over denture, I want it to fit beautifully into the sulcus all the way around. So I use compound, green stick compound, and just border mould as I would do for a complete denture. Really go for it. So we've got that lovely functional depth of the sulcus. So the sleeve's going to seal it when we make it. And then use Imprigum for the impression. So I've got my syringe here, and I'm just going to squirt it underneath, all the way under, all the way under. Just make sure it's properly in. I've got my tray loaded, so I'm squirting it right under the Luxabite, so we get a nice soft tissue impression underneath, and then put my impression in, sit it right down, and then do my border moulding. You know, cheeks, waggle the jaw, make sure it's really well trimmed. And then take it out, and then Rowan attaches the implant analogues, so we've got a perfect replica, or as close as possible to the mouth. So, and then pause that like this. So, and he does a soft tissue model of the, just over the implant fixture heads. So, and then I do a wax rim, carve that, exactly the same, lip support, incisal plane, occlusal plane, buccal corridor, centerline, OVD. Keeping it level, I'm going to replace this lower bridge and correct this area here, so don't worry about that open bit. Just doing the same method, and she wanted this lovely Nanny McPhee arrangement, you know, with that front tooth forward, so that was very much part of what she wanted. So we do a full try-in, because I want to make sure we get the teeth exactly where she wants them to be before we make all that super expensive bar that's going to fit underneath it. So verify that. So here's a full denture there with that tooth kicked forward, and just copying the photos. And she, you know, really carefully, very, very carefully, I say, I want you to be, Emmy, I want you to be super fussy about this. If there's anything you don't like about it, please let me know and we'll change it. Because we can't do it. We can't change it once it's finished, you know, once we get further forward. And doing this video is just great. She can really see herself socially, look at herself, you know, it's a really lovely technique. And she looks at herself really carefully on the video and assesses that with Claire, and then gives us a thumbs up. So here we are. So once she's happy with that, the model and the wax work, we send that over to Createch, which is part of Straumann. They're based in Madrid, where they mill this lovely titanium bar. But before they actually do it, they send us this file back, and then Rowan and I can sit down and look at it on the computer and make sure that all of that metalwork and that componentry is going to fit within the confines of the denture. So we have a good look at that, and we were really fortunate with Emmy, because the Nanny McPhee tooth here actually worked, because there's an implant just there, just forward, but we could actually position the teeth further forward on that particular place. We were just fortunate with it. There you can see it. That's the upper left central, just there, where that ankylosing implant is. So just fits over. So what we get back so we wait, and they send us back this. So this is the bar that will be fitted into the mouth. On that bar, we've got 3 locator attachments on it. So this part's going to fit in the mouth, and then there's a sleeve that fits perfectly over that bar of titanium. And then Rowan's going to make the denture onto that sleeve. That's how he does it. So this all fits over. So this is the sleeve here that Rowan opaques, and then puts in the locator attachment housings, and then really carefully copies that try-in using a silicone index, fits it all together, and then processes that to make the denture, the overdenture. And in these cases, I'll give them 2 because, to be honest, I don't really like implants because they just do not operate like natural teeth. They have no give in them at all. You know, they're ankylosed into the bone, there's no periodontal ligament, there's no give at all. So basically the patient just brooks on them without knowing, there's no feedback, mechanoreceptors, and break stuff. Much easier. So with these cases, I give them 2. So Emmy wears 1 on Monday and then 1 on Tuesday and swaps it. So when one breaks catastrophically, as in the tooth snaps off, she's totally used to the other one. And both of them have worn at the same rate. So the way it fits on the bar, any internal wear is the same. So she's totally used to it. It's not like, oh, I've got to go to my spare and then, oh, flip, it doesn't fit. What am I doing? You know, Dickie's Meadow, that's what we call it in Lancashire when that happens. We're in Dickie's Meadow. So, but that's all the componentry underneath. You know, it's really difficult. You've got all these different abutments and screws you've got to put in. It's a real faff. So it's much easier to just do an overdenture on top of that. But this is the case here, finished. You know, it just sits nicely over, superimposed. I'll show you that again so you can see it underneath. So we want all that metal componentry underneath, just there. And it's really important that you can clean it as well too. So if you imagine now this was a fixed restoration with teeth on, it would actually be ridge lapped and there's no way she'd be able to clean it at all. So that's the finished product, and we really distressed it as well. You know, we put in little cracks and staining, a little bit of a filling up at the top here, spaces. So that's a sleeve overdenture, that's a zirconia bridge in the mandible just there. And if we didn't have these photos, you just wouldn't be able to produce that type of work. So that's it. Thank you very, very much for your attention. It's been great being in Australia. I've loved it. Really, really good.